Selective serotonin reuptake inhibitors, or SSRIs, are among the most commonly prescribed medications for depression and anxiety. They are considered first-line treatment due to their targeted mechanism and improved safety profile compared to older antidepressants. Despite this, careful monitoring is essential to ensure safe and effective outcomes. Two common prototypes are escitalopram, Lexapro, and fluoxetine, Prozac. Both enhance serotonin, but Lexapro is often better tolerated, while Prozac has broader indications and a more activating effect. To understand how SSRIs work, it's important to review basic neuronal structure. A neuron consists of dendrites, a cell body, an axon, and an axon terminal. Communication between neurons occurs at the synapse, the small space between two nerve cells. The first neuron is referred to as the presynaptic neuron. The second is the postsynaptic neuron. The space between them is called the synaptic cleft. Within the presynaptic axon terminal, neurotransmitters such as serotonin are stored in vesicles. When released into the synaptic cleft, serotonin binds to receptors on the postsynaptic neuron. After signaling, serotonin is normally reabsorbed into the presynaptic neuron through the reuptake transporter. SSRIs selectively inhibit this reuptake transporter. By blocking reuptake, serotonin remains in the synaptic cleft longer and accumulates in higher concentrations, increasing stimulation of postsynaptic receptors and enhancing serotonergic signaling. Importantly, SSRIs increase neurotransmitter availability without directly stimulating receptors or forcing serotonin release. Instead, they prolong its presence in the synapse. Over time, the sustained increase produces neuroadaptive changes that improve mood regulation. Clinically, SSRIs are prescribed for major depressive disorder, generalized anxiety disorder, and post-traumatic stress disorder. Because serotonin regulates mood, anxiety, sleep, and emotional processing, increasing its availability helps stabilize mood and reduce anxiety symptoms. Fluoxetine, or Prozac, also carries FDA approval for several additional psychiatric conditions. Beyond these primary indications, SSRIs are also effective in conditions such as migraine, chronic pain, and premenstrual disorders. Serotonin influences both mood and pain pathways, so increasing its availability can reduce symptom frequency and severity. Despite their benefits, SSRIs are associated with predictable adverse effects. Common adverse effects include gastrointestinal distress, insomnia, and sexual dysfunction. Nausea and diarrhea occur because serotonin receptors are widely distributed in the gastrointestinal tract. Insomnia may result from early central nervous system activation. Sexual dysfunction is linked to serotonin-mediated suppression of dopaminergic pathways, reducing libido and arousal. Escitalopram has fewer drug interactions and a shorter half-life. Fluoxetine has a longer half-life, may be more activating, and is approved for additional conditions. SSRIs carry a boxed warning for increased risk of self-harming thoughts and behaviors in children and young adults under 25. Risk is highest during the initial weeks of therapy and during dose adjustments. During weeks 1 to 2, mood improvement is often minimal, yet energy may increase, temporarily raising self-harm risk. By weeks 2 to 4, gradual mood stabilization and anxiety reduction typically occur. Full therapeutic benefit is usually achieved by 3 months, and many early side effects diminish. Nursing priorities during this period include close monitoring, reinforcing adherence, and ensuring patients do not discontinue therapy abruptly due to withdrawal-like symptoms. SSRIs are contraindicated with monoamine oxidase inhibitors due to the risk of serotonin toxicity. A 14-day washout period is required when switching between SSRIs and MAOIs. Caution is also necessary in younger populations and in patients with liver disease, where impaired metabolism may lead to drug accumulation. SSRIs should not be combined with other serotonergic agents, including MAOIs, ondansetron, and herbal supplements such as St. John's wort, due to the risk of serotonin syndrome. This condition presents with agitation, fever, tachycardia, tremors, and muscle rigidity. Concurrent use with NSAIDs or anticoagulants increases bleeding risk. Grapefruit juice should also be avoided, as it interferes with hepatic enzyme metabolism and may raise drug levels. Key nursing monitoring priorities include assessing for worsening depression or self-harm ideation, signs of serotonin syndrome, sleep disturbances, weight changes, and hepatic function in at-risk patients. Ongoing patient education is critical, as SSRIs require time to reach full effectiveness and must be tapered if discontinued. Patients should understand that full benefit may take several weeks, sometimes up to 12, particularly with fluoxetine. Medications must never be stopped abruptly. Any worsening mood, agitation, or unusual physical symptoms should be reported immediately. Prozac's long half-life allows more flexibility with mixed doses, while Lexapro requires consistent daily administration. SSRIs remain foundational in treating depressive and anxiety disorders due to their selective mechanism and favorable safety profile. Their effectiveness depends on vigilant monitoring, patient education, and awareness of serious interactions. When used thoughtfully, SSRIs significantly improve patient outcomes while maintaining clinical safety. Understanding pharmacology for elevated patient care.